was going to talk about flow diversion, and really this is intended for people who aren't doing endovascular work and who just sort of see us slamming in pipelines everywhere and have really sort of no sense of when it's appropriate and when it's not. And certainly there's a lot of controversy and change and um, a very evolving field. And when I was putting this together, I uh, thought I would be talking more about the edges, about how it's moving and where it's going beyond the um, approved indications. And I realized fairly quickly that probably it would be better if I broke this into two separate talks. And so this is really going to be the first talk. And if you survive this and want to listen to the second part of it, then we'll talk more about uh, what's happening and how the treatment is evolving. Um, so this is really part one for the non-endovascular neurosurgeon. I'm going to be talking about off-label stuff as well, though, and I have disclosures. So the really we're going to probably only get into the first two parts of this, sort of some of the little principles of flow diversion. I'm not going to spend much time on that, and really just what I want to talk about today are the trials that really are the basis that have gotten flow diversion to be accepted, approved, and how that evolved over time. Flow diversions come about because endovascular treatment, particularly coiling of aneurysms, actually doesn't work very well for aneurysms bigger than 10 millimeters. And we see that if we go back to Ramon's work from the early 2000s, the recurrence rate, retreatment rate in aneurysms bigger than 10 millimeters is more than 50%. So that's really the impetus for doing something different, having something that excludes flow to the aneurysm other than coiling. So this is, the flow diverter, a flexible stent-like device, and the only one that's available in the United States is the pipeline. And the pipeline is a braid, a woven braid of 48 strands of cobalt, chromium, and platinum for radiopacity. And it generally has about a 30 to 35% surface coverage when it's deployed in the artery. You can manipulate that when you're placing it, so you can compress it and make the coverage denser. You can stretch it out a little bit and make it less dense, and you can overlap devices to make a longer construct, telescoping them into one another and getting double coverage or sometimes even triple coverage. And this is an image going back to 2009 when it was still under trial. From a publication we put out that Dave Fiorella was the lead author, and this picture here was the cover photo for the first issue of the Journal of Neurointerventional Surgery. So it's kind of an exciting time, a lot of interest, expectations, and people were starting to see some of these pictures where you'd have these giant cavernous aneurysms in the frontal view here, place the device in the lateral view here, and see this kind of stasis, and that's what we were all looking for. And what was completely different about this was that over time on the cross-sectional imaging, you would see the device here, the aneurysm there, and then you would see the aneurysm fairly quickly thrombose, and following it out, you'd actually see that shrink. And so that was a real game changer, seeing that we're actually having these shrivel and disappear. And again, the frontal view of the follow-up was what we were, of course, looking for. So the trial that led to approval was the PUFS trial, Pipeline for Uncoiled or Failed Aneurysms, and this was really reported pretty recently. 2013 was the data publication, and there were 10 centers that were involved, enrolled 108 patients. There were really only about 5 centers that enrolled any number of patients, and in Phoenix we contributed 25 to 30 of these patients for the trial. So we were fortunate that we sort of started this early on, and because there were so few centers that were actually able to treat these patients, people were excited about it, and we're trying to move away from coiling. We had a nice referral pattern from across the country. Now the trial was restricted to aneurysms of the internal carotid artery from the petrous segment to the superior hypophyseal. So we weren't supposed to go beyond the superior hypophyseal, nothing in the posterior fossa. The aneurysms had to be at least 10 millimeters in size, and they had to have a neck of at least 4 millimeters. So these are the big bad aneurysms that recurrently failed with previous endovascular treatments, whether it was coiling or stent coiling or whatever. There were follow-ups at 30 days, 180 days, with a telephone call at 90 days. And there was an independent core lab looking at the degree of occlusion, any stenosis, and any migration of the device. Um, there was an independent ophthalmologist every patient because the vast majority of these were having the device cross the ophthalmic artery and it wasn't clear whether the ophthalmic artery would stay patent, whether it'd be throwing emboli. So everybody in the trial got neuro-ophthalmological evaluation at 6 months. And then the endpoints were really complete occlusion, just a yes/no, uh, with less than 50% stenosis was considered a favorable outcome. Less than complete occlusion or more than 50% stenosis within the device was not a good outcome. And then the safety endpoints were major ipsilateral stroke, neurological death within 180 days after the pipeline placement. And this was just a flow diagram of the patients. And it's almost readable. The main thing being, 111 people recruited. A few dropped out because they didn't actually meet the enrollment criteria. Ended up with 107 patients treated that went through discharge assessment. The deaths were 3 and ended up down here with 97 patients at 180 days undergoing angiographic evaluation and 100 patients actually being available for clinical follow-up. I'm sorry, I didn't hear. Tortuous anatomy, just atherosclerosis, stenosis. Um, we sometimes spend hours actually trying to get past the aneurysm. So the really big aneurysms, you can't find the exit, you can't find get the catheter into the artery on the other side of the aneurysm. And that was a fairly frequent struggle. The device was, despite those difficulties, placed successfully in all but one patient. And at the time, the longest device available was 20 millimeters. And if you compress it, it would end up shorter than that. And a lot of these aneurysms were giant aneurysms, more than 25 millimeters. So the necks of the aneurysm would be 15 millimeters, and you need 5 or 10 millimeters on either side, so you had to telescope these. So today we're using fewer devices per patient, but at the time of this trial with the shorter devices, it ended up being the average was 3 pipelines per patient, which again, if you can get away with fewer, that's a lot cheaper. This is the patients that had a safety event, and there were 6 patients that had either major stroke, hemorrhage, or in a couple of instances both, and with fatalities, I think in 3 of them at the 180 days. The occlusion rates at 1 year were really very gratifying. Complete occlusion in almost 87%, residual neck in another 5%, and residual aneurysm really only in 5%. There were a couple of carotids that went on to occlude, so asymptomatically, 2 of 91 at 180 days. The modified Rankin score, so the clinical outcomes were excellent. They were improved in 21 patients of the 107, unchanged in another 65%, and worse in just under 10%. So that trial was published in 2013. We've since had publication of the 3-year follow-up and submitted for publication, but not yet publication, is this, which is the 5-year results of this trial. So the trial was 5 years of follow-up, and as I said, this has been submitted, and I expect will come out fairly soon, but is not actually been published yet. It's been presented, and so this was the standardized follow-up, which went on at 6 months, 1, 3, and 5 years, and these were really the secondary outcomes of the trial, which were evaluation of whether the aneurysm was occluded, whether there was any in-stent stenosis, the clinical modified Rankin score, and any delayed complications. So looking at the independent core lab rate of aneurysm occlusion. We saw at 6 months there was 73%. By a year, we're up to that 87% number. And unfortunately, getting people to come back for angiograms is harder, so you start to see some drop off in the actual numbers, 76 at 3 years, 63 at 5 years, but you see that the trend is for increased occlusion of aneurysm. So the results are, appear to be getting better with time um, instead of recurring. If you looked at the aneurysms that still had some filling at 6 months and saw what happened to those aneurysms, 6 of them were retreated, 4 of them after retreatment, which basically meant placing another layer of flow diverter. 4 of those 6 went on to complete occlusion of the aneurysm, and of the 9 that were not retreated, 7 of those went on to become completely occluded at follow-up. And I think there were other 2 didn't have follow-up imaging, didn't come back for follow-up. So there were 4 aneurysms in the trial that were never imaged to show they were occluded. They didn't have long-term follow-up. Uh, but the last follow-up that they were seen at, they still had residual filling. And of those aneurysms, the mean size was 19 millimeters, so they're big aneurysms, and the neck was almost 15 millimeters, which is bigger than the average in the trial. So they were the aneurysms clearly are problem aneurysms when you've got a 15 millimeter neck on it. A little troubling are the parent vessel occlusions. 6 vessels were lost, becoming occluded. Uh, Fortunately, 5 of the 6 were neurologically silent, but it speaks to the collateral and the location. And when you start putting this device in other places like the basilar artery, where an occlusion is not likely to be so forgiving, it should give you pause. And there was one additional device that had more than 50% stenosis but was asymptomatic. At 5 years, the modified Rankins was less than 2, equal or less than 2 in 96% of patients. So again, pretty good clinical results. And overall, in the trial, by 5 years, there were 4 deaths. Remember, I mentioned 3 at the beginning in the first report. One patient died of a malignancy 2 years after treatment. So there were no additional treatment-related deaths. Um, in terms of new device-related adverse events, at 1 year there was 1 additional event. By 3 years there were 3, and there were no new events between 3 and 5 years. So there doesn't seem to be a lot going on late or delayed. There were no delayed neurological deaths, no hemorrhagic or ischemic events, no aneurysms ruptured beyond 6 months. As I think I mentioned already, that there were 6 aneurysms that were retreated, and 4 of those 6 were essentially cured, and there was no recanalization of previously occluded aneurysms. So again, something we just haven't seen with endovascular treatment before, short of parent vessel sacrifice, is essentially a 0 recurrence rate in the trial. So the conclusion of the 5-year results were that we've got a high rate of aneurysm occlusion, low rates of delayed complications, and no recanalizations. So meanwhile, as this trial was taking 5+ years to recruit and follow and unfold, the device was approved in 2009, so people are starting to use it and starting to use it in off-label ways. And the real question was the centers that were originally chosen were fairly large volume centers. We're doing a large volume of the pipelines, and naturally the question is this generalizable to practice beyond select centers? And most recently, Dave Kalmas, who's out of the Mayo Clinic in Rochester, has combined a pooled analysis of 3 trials. And those trials were the PUS trial, so the one we just presented, and then the Intrepid registry, which was a retrospective registry, and the Aspire registry, which was a prospective registry. So to participate in these 2 registries, which I did, you had to agree to include all your patients, so there was no cherry picking, was really the basic thing, and then have everything reviewed. prospectively in the Aspire and retrospectively in the Intrepid. And the data from that allowed primarily clinical outcomes. So because the Intrepid trial was a retrospective one, there was no core lab to adjudicate the actual angiographic results. So it's primarily looking at clinical outcomes, looking at major ipsilateral strokes, intracranial hemorrhages ipsilaterally, neurological morbidity, mortality, and the combined M&M. And the advantage of these registries were much bigger numbers. So we had uh, almost 1,100 patients with 1,200 over 1,200 aneurysms. And what you see is that as this technology is released and there's no restrictions other than the physician judgment, you see the aneurysm size is a lot smaller. So in the PUFS trial, the average size was about 18 millimeters, so 50% bigger than this, and similarly the neck size was smaller. So the device is very quickly starting to be applied to smaller aneurysms. And when you look at this much larger group, you see that the major ipsilateral stroke and death or stroke rate was about 3%. The ipsilateral intracranial hemorrhages, I should just sort of, it's not clear why these hemorrhages occur. So there are a number of different theories as to why hemorrhages occur. Typically downstream from the aneurysm, but remote from the aneurysm, parenchymal hemorrhages again, it's controversial as to why they occur, but they're seen at about 2% in this large series. Major neurological morbidity 5.7%, more neurological mortality 3% for the combined neurological morbidity and mortality of 7.1%. So I think the importance of this slide, the reason to mention this is that um, as this device becomes more widely adapted and applied to smaller aneurysms, you really have to think about whether it's appropriate to be treating, a 4 millimeter aneurysm of the supraclinic carotid, because there is significant morbidity and mortality to using this device. The occlusion rate in this combined pooled series was 85% at 1 year. The unfortunate thing is that's not that many patients that actually were included in the imaging, why it's primarily a clinical registry, and most of these patients are in fact PUFS patients, so that's really no different than the PUFS trial. Um, in Phoenix, we looked at our own series of cases after approval, looking at what we thought our single center complication rate was, and tracked that we have had a prospective database. We tracked that all patients, so there were a consecutive series of patients during the 2-year time frame just after approval to 2013. We had 126 patients during that time frame with 137 aneurysms. We had gone off the reservation a little bit off label and had treated both a cervical carotid and a cervical vertebral artery dissection and one CC fistula, but the rest were all intracranial aneurysms. Our demographics showed an age range around this column are the patients that had complications. This column are the patients that did not. All patients, the combined series, and you see there wasn't much difference in terms of the age of the patients. So it wasn't older patients who were having the complications. The population is heavily skewed towards women who seem to have the large cavernous aneurysms. And we had 31 complications in 121 patients. The aneurysm size slightly larger in the complicated patients. We had both anterior and posterior circulation in patients, and if you look at the posterior circulation, our complication rate was 7 out of 16, so almost 50% of patients in the posterior circulation had some complication. And there was really no difference between whether the patient was an on-label patient or an off-label patient. So it didn't seem to didn't raise the complication rate by going off-label. We had 40 complications in 33 patients, with only 4 of those being permanent complications. So we had a 3.2% rate of essentially death and stroke. So, what the kind of point of this is that when I counsel patients now, I tell them generally that there's an under 5% rate of stroke and death, disabling changes that are going to ruin your quality of life or be fatal. But there are a lot of bumps along the road, and some of them are minor, and some of them are more frightening and more concerning. But it's not rare to have complications with the use of this device. The four permanent ones were delayed thromboembolic complications in 3, and then 1 contralateral hemorrhage. So if you look at the temporary complications, we sort of broke it down into procedure related. We had 4 vessel dissections. Those occur because a lot of times these are patients with tortuous anatomy. You're having to use big catheters. You have to get them up close to the skull base to have enough support. So you're fairly aggressive in putting big stiff catheters into the proximal arteries. Groin hematomas, vessel perforations, UTIs. So you can see that urethral trauma from a Foley. So it's a pretty inclusive list of complications. Temporary complications that were device related. We had 2 side branch occlusions, so like crossing the ophthalmic artery if you lose the ophthalmic. We had 1 intraprocedural occlusion of the pipeline device, so an acute thrombosis, and we had the delivery wire break and be retained in the patient. Delayed complications, I think I've already mentioned the delayed occlusions, TIAs, shrinkage of the device, I'll show you a picture of that, and then deficits from mass effect after treatment of an aneurysm. So often if you get good thrombosis of an aneurysm, no matter how you do that, there'll be some mass effect and edema, which is typically managed with steroids fairly readily. We had 1 delayed cavernous aneurysm, which presumably went on to rupture and create a CC fistula that had to be treated. And then, as I said, another delayed occlusion that was side branch. We had 3 delayed GI bleeds, so that's the dilemma of the aspirin and Plavix. If they're not an aspirin and Plavix, then you're having stroke risk. But GI bleeds, nosebleeds, all these things can be problems. This is one of the complications where they had intraprocedural occlusion of the parent artery, and this happened as a result of this device here. You can see as it's being released, it's not expanding well, and despite all attempts to balloon and open that, you can see at the end of the case there's still a waist to that device, which means it's not well opposed to the wall of the vessel, and this becomes more thrombogenic, and there was occlusion with sort of sluggish flow, which was felt to be dangerous for embolic risk, and the artery was then sacrificed, knowing that there was good cross filling there. This patient here originally presented with this basilar trunk aneurysm, and at the time this patient presented, there was no access to the pipeline device. It was after completion of the trial but before approval, so this was kind of temporized with coiling, and we see a large recurrence of the aneurysm here, and that might have been something we could have mitigated had we stented that, stent coiled it. I deliberately didn't stent it because I knew the pipeline device was going to be available. I was anticipating a recurrence and having to retreat it. So this was treated with a pipeline device that was placed here. There was actually 2 devices. The first device came up a little short right there. Second device nicely covered the whole thing, but the tip of the delivery wire actually broke off. Probably as you're delivering the device, it moves forward and you can't steer that. And at the time of delivering it, I thought it was going into the PCA, but it was probably going into perforator next to the PCA, and then ultimately broke off and was retained without clinical consequence. And then contraction of the device is another sort of complication we encountered. This was a patient who had this recurrent aneurysm after clipping. It was probably a blister type aneurysm that recurred, and in order to deal with that, we elected to place a pipeline device, and you see the end of the device right here, nicely covering the aneurysm. But at follow-up, there's persistent filling of the aneurysm, and then if you look, the device now ends there. So it was probably not sized quite correctly. It's shortened a little bit, and so there was filling uh, of the aneurysm, and then a second device was telescoped into there. There's the end of the second device, and that went on to resolve. Why does the patient have? Yeah, yeah. So this aneurysm was clipped. This is a recurrence after clipping. We have a large series of those. No, so this is Philippe Albuquerque and my sort of personal series of post-approval complications. Um, so this was not a study patient. Actually, might have been in the Intrepid registry or the Aspire registry, but was not part of the PUFS trial. This was sort of real world once it was released and approved. So again, in our hands, we had a high temporary complication rate, almost 30%, but we had a very low uh, permanent complication rate of stroke and death, a clinically significant stroke and death. So kind of bottom line is there's a pretty good body of data, both from PUFS, from Intrepid, and Aspire registries, where we've got a fairly large number of patients, pretty consistent risk profile. Our personal series kind of in that ballpark, and I think the take-home message is that it's a pretty safe and effective device. And then if someday in the future you can stomach, I'll come back and we'll talk about what sort of the controversial areas are as people are starting to push the envelope with this, and what the real issues and concerns are as it gets expanded in its use and as other competing devices start to get approved. So that's all I had, unless there's questions.